Good morning, everyone. Welcome to our, today we've got a special session here with Dr. Eugene. So he's currently a consultant EP lah, right, in Perth, Western Australia. He's been a consultant there since 2021, and he's actually an ex-MO from HRPB as well. So that is why we are actually gotten a chance to hear him talk here to explain about FRCEM, all right, how's the process, how we apply, what are the, good stuff that we can get. All right. So without further ado, I'd like to invite Dr. Eugene to present his slide on FRCEM Q&A catch-up. So please, Dr. Eugene.
Hi, good morning, everyone. I'm just going to take off my mask. Everybody's within 2 meters, and I think it's easier that you can see what I'm talking so that you all can understand. I don't want to give you rote information which you can read from the website. Everything all right? Okay.
Some technical issue.
That's all right.
Oh, yeah. Dah share dah. Moving our screen je lah.
But you don't need to.
No issue with the Zoom. Just this is the monitor issue.
But they won't be able to see. Are you guys happy to see it?
Yeah, it's fine. You can just see it from.
I will share my slides in a second, so don't be too worried about it. So a little bit of a backstory about me. I finished my medical degree. I worked in Seberang Jaya and then worked in Taiping and worked as a registrar here. And that's when I sat for my membership exams and then decided to migrate. I finished my entire training in the United Kingdom, completed the CCT, and worked as a consultant for a bit before migrating to Australia. So So the main reason I'm here today is MFRCEM pathways now, and it's like this parallel pathway. When I was doing it, I was listening to having MRCEM pathway established. So I'm quite glad that there is an acceptable pathway. Everybody is working towards specialization through an alternative route. Now, there are a couple of questions today. I've got about questions, and hopefully I'll be able to answer your questions. If I don't, I'm happy to stick around for the next ask some particular questions. But like I said, if there are information which is readily available on the website, then I'll be directing you to the website. Okay, thank you. Now, so first question. What is a quality improvement project? Now, when I did the FRCEM, I completed my FRCEM in 2018, and that time the college mandates you to sit 7 papers before you finish the fellowship exam. So they had the critical appraisal exam. So after you finish your MChem, you sit for a critical appraisal exam. You sit for your SAQ FRCEM, you sit for your OSCE, and then you sit for your quality improvement project. The quality improvement project itself was a very laborious thing. They had very specific indicators, specific marking system. But fortunately, the college has changed the requirements of the exam right now. You do not need to sit for the QIP anymore. You do not need to sit for the critical appraisal anymore. So FRCEM is much more easier and attainable right now. But to answer the question about QIP, but to sit for your training and to get the CCT in the United Kingdom, you still have to do the QIP. That's part of the training. It's a training outcome. So just to give you a little bit of understanding of quality improvement projects, quality improvement projects or QI methodology itself is a beast on its own. It's very difficult to explain or even lightly touch about it, because if you know about research methodology, about qualitative, quantitative assessment, how you collect data, how you analyze the data, quality improvement itself has its own way of doing it. You have your own methodologies. You have IHI model for improvement. You've got Lean Six Sigma. You've got Tai Chi Ono's model for wastage reduction. So you've got a lot of those. But essentially, QI, especially where healthcare is concerned, QI originated from the industry. So from Toyota, that's where it came from. Lean methodology, for example, and it's been used in healthcare. So certain models are quite useful for healthcare, where there's private or there's kind of funding from the private sector. Certain health models are more relevant for a government-funded kind of healthcare system, like in UK or in Malaysia. It has its own science. Of course, the way you measure, the way you do your run charts, the Shuha charts, and all of that are all very, very proprietary to quality improvement methodology itself. To learn a little bit more, the college actually has got very, very useful information about QI. You can find it on the RCEM Quality Improvement Guide. The link is on my slide, so you can click, have a read. And I think the college has done a very good job in explaining everything from the basics, so you won't be too confused about it. So that's pretty much about QI. Essentially regard it as there's an itch behind your back, you're very irritated about something. Like one of my quality improvement project for the FRCEM was about improving how patients who present to the ED with first episode of seizure are treated, and how they access their first seizure clinic. So I did it over 3 years. I got it published in a Q1 journal. So that's the kind of level that they're expecting. But like I said, there is no longer a mandatory component for the FRCEM exams. It was about 2 years ago. That's pretty much it about QI. Those attending on Zoom, can I just check, are you all happy with how fast I'm speaking? You wanting me to speak a bit slower? Now, the question here is about MRCEM versus the FRCEM. And to answer this question, you need to understand how the UK training system works. The training program for emergency medicine in the United Kingdom is a 6-year program, in which your ST1 or CT1, 2, 3 is what we call your junior training years. And then you enter into ST4, ST5, ST6, in which is called the highest specialist training program. Now, you will do your basic rotations like emergency medicine, anesthesia, intensive care medicine, peds emergency medicine, all throughout your first 3 years, okay? The aim of the MRCEM is, it is an entry examination into higher specialist training in the United Kingdom, which means if you do not pass, it's a bit complicated now because you don't need your MRCEM to go into higher specialist training in the UK, because MRCEM has been offered as an extra exam. But previously, during the years, the MRCEM, you cannot enter into HST or your higher specialist training without sitting for your MRCEM. I think what the college did to offer MRCEM is because the college has changed the exam requirement about 3-4 times in the last 6 years, and it's very confusing. Even I don't really understand it now, but the entire idea for trainees is that you sit for FRCEM MRCEM primary, you sit for your first part, second part, and then you get the intermediate cert at some point, and then you continue on to training. So that's relevant for the UK trainees. For those who want to sit for the MRCEM, for many other reasons, the college has offered MRCEM. There was one point they wanted to stop the MRCEM being offered because they felt the MRCEM OSCEs were repeating the FRCEM OSCEs, which I disagree. We'll come to that point in a second, okay? The FRCEM is an exit examination, okay? you go through your entire training 6 years, you finish all your assessments, you go through all your ARCPs. ARCPs is every year you have a review, and then the panel decides, this guy is functioning at whichever level he's supposed to function at, and then you bump you up to either ST4, ST6. You complete your entire training program, you sit for your FRCEM, and then you send in your paperwork to the General Medical Council, and then you're on the specialist register. That's how it works. But the FRCEM is the quality and what you would expect of an FRCEM positive candidate is someone who is expected to function as a first-stage junior emergency medicine consultant in the United Kingdom. And this is a very important point because this will answer the next couple of questions ahead. Does everyone understand the difference? I will talk about the FRCEM OSCEs in a little bit more in detail, but any particular questions on this topic so far? So you can easily pass your MRCEM. It's not a difficult examination. If you're working in emergency medicine, you know what you're doing. A lot of stuff is basic, and the type of communication, you have certain templates. You can easily pass your MRCEM because MRCEM focuses on knowledge. What kind of emergency medicine knowledge you have. So you're going to have resuscitation scenarios. You're going to get all the resuscitation. If you follow your protocol, you will pass the exam. If you come to a physical examination station, if you do it according to how you do in a basis scenario, you will pass the exam. There's no difficulty in passing the MRCEM examination. Now, let me go to, let's answer question 6 because I think it's a bit of a relevant question here. So is it possible to pass the FRCEM OSCE without working in the United Kingdom? My view on it is chances are a bit low. And I'm not here to discourage you. Like I said, the FRCEM exam is for someone who to function as a consultant, first-day consultant in the United Kingdom. And I'll give you an example, okay? So for my FRCEM exams, I had very, very little clinical knowledge stations. That knowledge, so let's say you compare the pie chart for MRCEM OSCE in a particular station, and you compare the pie chart of FRCEM OSCE, the station might be the same. So you might go into a cardio station, physical examination, and the task for your MRCEM OSCE will be, perform a cardiovascular examination on this patient, formulate a diagnosis, and come out a management plan. That will be an MRCEM station, OSCE station. An FRCEM station would be teach the medical student how to conduct a cardiovascular examination, go through, provide some feedback, and answer the question. That will be an FRCEM OSCE station. So it's expecting you to function at a specialist consultant level. A lot of my stations were dealing with very difficult patients, dealing with difficult family members, and this resuscitation scenarios do not focus on asking you. So let's say, so my station was a pediatric trauma station. That was fine. Patient comes in, 20-minute station, resuscitate, but they are not interested to know whether you can resuscitate the child or not. The MRCEM OSCE would have told them that, okay? So the marks for following the, so if that's it, like there's 20 marks expected in the FRCEM OSCE station, the knowledge aspect of it will only be 1 or 2 marks, that's it. The rest of the 18 marks will be, I'll tell you my exam scenario. It was a 5-year-old child. You've been given help. There's a nurse with you. There's a F2. F2 is like a house officer. So with you, who's helping you. And you are asked to resuscitate the patient. Okay. So I was in the station, resuscitating this child, ABCD approach, everything good. And then the F2 starts arguing with you to ask you about the role of ultrasound in a 5-year-old child in trauma. So they see how you prioritize, how you make decisions, how you resuscitate, at the same time, how you explain to someone who's teaching you, or someone you are teaching, what is the role of ultrasound. So these are things that they're looking at the FRCEM OSCE level. And then it doesn't end there. About the last 5 minutes of the station, the mother runs into the room, starts crying, and then you have to manage that also. So that's the FRCEM OSCE station. Okay, so that's just to give you a little bit of an idea what is expected. Actually, so I published the paper because I said for the MRCP, and I published a paper in the Education Medicine Journal from USM, and particularly I wanted to publish it in a Malaysian journal because I felt that one of the biggest problems with people, non-UK trainees, is the communication station. Okay, the expectation of what you would have in a Malaysian healthcare system and expectations of patients in a UK NHS or Western country is very different. And it's really important for you to understand that. There's a lot of science behind it. It's called Hofstede's cultural dimension theory. And the whole idea is you need to understand, and a lot of preparation should go into how you actually communicate in the station. Because a lot of people fail just purely because of that. Especially in the PACES, especially in FRCEM and even MRCEM. If you get a communication station, you will get communication stations in the MRCEM OSCE. That's probably where you should focus your efforts on. So the principles for whatever I've published in my research is the same with, and I feel it would be probably useful for you if you were to read through it. So the link is already here, so you guys can have a look through, okay? Where were we? Now, can I just confirm everybody's sitting for the MRCEM exams? Has anyone passed the MRCEM, full MRCEM yet? One question I asked all of you. Has anyone gone through the college website and looked through the college curriculum? So how much is the MRCEM examinations in Malaysian ringgit? How much does it cost you?
You mean the total, is it?
Yeah, the total.
Around 10K.
And including your flight to UK, your time, your books and all of that?
No, it's available in Malaysia. I mean, it's
Up to the party, is it? Okay. Fine. Okay, I mean, at least that is a bit easier, but I think what I'm trying to get at is if you're sitting for an exam which is expensive and which has a what we call by high stakes examination, your first resource should be actually looking through the curriculum and understanding what the exam wants out of you. Okay. My background in medical education, based on what I can do, every exam has the exam blueprint. And you need to look at the blueprint because based on that, you will know what the exam can and cannot ask you. Okay, and so that you have a better understanding of what the exam wants. I had in my MRCEM station a patient with pyoderma gangrenosum. Okay, that was the diagnosis, and the whole idea is they gave you a guy who was sat in the room. You ask the history. He says, "I'm here for a rash, doctor." He shows you a picture of the rash, and your job was actually to describe the rash and come up with a differential on what you think the rash would be and how you work up the rash. And that's within the remit and the syllabus. Okay. And the next station was putting on a Thomas print. Okay. You will most of the time get a suturing station in MRCEM. That's a given. Most of the time, it's very rare that you don't get it, and those are easy marks. Okay. So to answer your questions about the resources, there are good books. There's one from Kiran Somani. There's a handbook for Oxford. No, not a handbook. It's an Oxford specialty training book for MChem. I think FRCEM OSCE, MRCEM. So you can have a look. So my advice for you is the college actually takes a lot of time and effort to actually help trainees pass the exam. And the RChem learning website is a very useful place to learn. there's a lot of questions that you won't get a certificate if you don't have membership, but you can access the questions, you can look at it, and some of the questions have actually come up in the exam. Okay, at least finish the SBAs or the questions in the RCEM learning database. There are lots of resources. I think at the MRCEM level, a lot of them are pretty all right. FRCEM success, I felt it was more of an MRCEM level rather than FRCEM level. But the key take home is understand what the exam wants of you. Read, follow the RCEM learning platform, because there's lots very good information and resources there. And I think the tip about the SBA is timing. A lot of people fail the exams because they don't time properly. So that's something you need to be mindful of. The OSCE, you have to practice. There's no way you can run away out of it. You can't practice. You can't sit for the exam on your own without practicing for the OSCE, and you need to get regular feedback. What I felt useful was even actually recording yourself and seeing how you actually deal with the stations after that. You will really learn a lot after that. Now, this is, there's a lot to talk about this, working in the United Kingdom, how it is. It is a very different healthcare system. Expectations are different. The way people present are different, and the type of case mix and the type of the incidence rates for a lot of the pathology is also different. So, but at the same time, you are always supported. In the UK, it's had more, a lot of things are a lot of it are protocol driven. There's no chance for you to go rogue. Antibiotics are very well kind of demonstrated and kind of like set up on the hospital's protocols. And the NHS bases itself on its 7 pillars of governance, and a lot of your work all kind of circulates around that kind of idea. And as a consultant, we a lot of times on the shop floor. It used to be a consultant-led service many years ago, where the consultant is in the office. You come and ask questions, ask for advice. But trauma centers nowadays have a 24-hour on the shop floor consultant support, and that's the way these days. I mean, there's a lot of questions about how busy things are. It is busy. It's busy in UK. It's busy in Malaysia. It's busy in Australia. It's no different. I think the issues remain the same. Access block. So anybody has got particular questions on this question? Kind of to talk about this point.
Maybe in terms of like adaptation, like let's say we move there or we how do we like any tips to adapt to the working environment, any like guide?
So I think it will be difficult to adapt. Okay, especially if you move, it doesn't matter, you move on your own or you move with your family members. The best thing to start is networking. If you decide to move and take up a place in a hospital or something like that, look for people, Malaysians, there's Malaysians in a lot of places. Start getting to know the local and Facebook groups and stuff like that. Get to know people so that you're not lost, because it takes you at least a good 6 months, I think, to really understand the system and be functional. Does that make sense? You can't just walk in and then work in that system, because everything's very different. The pressures are high, and that's how it is. But at least the networking bit helps. A lot of the hospitals do offer a lot of support. They let you kind of like shadow for a bit, so you're not making the decisions on your own. And they don't really put you on night shifts until you're really 2, 3, 4 months into the system. Yeah. Any other questions? No, Iman. Okay. Okay, this, I get asked this quite a lot. Uh, so yeah, I mean, especially when you work in the UK and then you come back to Malaysia and then they ask you the question, hey, how much do you earn? And then, you know, as a non-training specialty registrar post MRCEM, you're probably looking at about 60 to 70,000 pounds as a non-tax figure. And you know, people in Malaysia say, "Oh, you rich man lah, you get 350,000 ringgit a year. Wow, that's a lot of money." It's not that accurate. Okay, number one, the tax system in the UK is painful. It's painful, and I'm being very, very polite here because I could use other words, but I think it's very painful in the UK. If you're looking at, if you're so I recently got a job from one of my colleagues, one of my friends. He passed his MRCEM. He's a Malaysian also. And he was given a pay of 72,000 pounds a year. Okay. 72,000 pounds, you will be taxed at 20%. That's your tax. No, that's not enough. That's just base rate. Okay. And then on top of that, you pay for national insurance, which 10%. So you get 30% removed. Okay. For those who hit the bracket above 80,000, you get taxed up to 40%. And then there's another 10% of national insurance which you need to pay. 72,000 divided by 12, how much is that? You don't get 6,000. You won't see 6,000. That's the conclusion out of it. You're probably seeing 3,200. Okay, that 3,200 depends where you live. If you live in London or you live nearby London, then you're looking at a rent. A single room apartment easily costs you 1,200 pounds a month. Okay. I lived in London for about 2 years and then I moved up to the north. Even housing, you know, housing scenario nowadays is a little bit of a bull run. So you're looking at least a full like 4-bedded house, a proper area, nice area. You're looking at 800 to 1,200 a month. Okay. You got other stuff. You have to buy a car. You need to pay for insurance. Insurance in the UK is expensive. You're looking at about 1,800 for just a normal car, 1,800 pounds a year. There are other taxes like council tax. You have to pay on a monthly basis. It's something like Cukai Pintu back in Malaysia, but it's expensive. And then you need to pay for your TV tax, which is about 150 in a year. You get very little. That's yeah. You can save. You can do extra locums, and you do get paid a good amount of money. But most of the people who come in under the tier 2 visa, which you'll be getting if you come in to work in the UK, you get tier 2 visa, then you're restricted to 20 hours a week of locum. Yeah. Yeah. So you can get the money, but if you really hit that bracket, then you get taxed more. Yeah. And you are looking at a decent meal in the hospital canteen will be costing you about 7-8 pounds, which is actually okay. Outside, you're looking at least about 15 to 20 pounds a decent meal. Food stuff is cheap though. You can buy fresh, good quality food, like you want to buy chicken, vegetable, you know, your milk, everything will come to less than 30 pounds. So if you cook on your own, you stay nearby, you should be all right. Yeah. You can save money. You can save money. It's not that bad. But yeah, there'll be a lot of people you need to pay. You need to pay the GMC, the yearly fees, which is about 400 pounds a year. You need to pay if you want to join the BMA, which is a medical union, something like MMA, so you need to pay for that. Once you pass your MRCEM, the college will ask you to pay for fees, or else you can't use the term, you can't use the post-nominal MRCEM. But all of these are tax deductible. As long as once you go there, and then you can claim back from tax. Any other question regarding salary, lifestyle, payment, how it works?
How about taxes on investments?
You will be taxed for capital gains. You will be taxed on dividends. but you can put your investment under what they call by ISA, and that will protect your assets right up to £20,000. Yeah. The taxman always come after you. I assure you, they will come after you. And then if they're not happy with you, they'll tax. It's called emergency tax. There's about 60-70% of your pay, you'll be left with peanuts. So don't try to escape the taxman. Declare what you need to declare. Yeah. Right. So any questions on this particular kind of topic?
How was your JD last time actually? I mean, because more structured because we have to pass MRCEM OSCE, then after we get the membership, then
Okay.
the total slide. So how about you last time? Because I'm sure.
Yeah.
So
So
you quit or what?
yeah. So I quit.
You quit
I
after
quit.
you finish your
MRCEM.
MRCEM OSCE.
Yeah, I quit. Yeah. Yeah, I'm not giving you all any ideas. Yeah, Dr. Kursi, the first thing he told me is make sure you keep this for this year. Don't brainwash them to migrate. I mean, I quit because MRCEM I passed. I think it was the first few to actually pass. I got my MRCEM in 2014. So there was no parallel pathway. Nobody knew what to expect out of an MRCEM candidate. So and I decided to leave. I got into training program in the UK, and I just finished the training program and worked as a consultant in the UK. So that was my journey. I think the structured training program is a very, very good way to go forward, even though it sounds a bit of a pain. Now, what I can give you in that particular aspect is you need to balance things in your life. And it doesn't really come as a very important thing right now. As you grow older, when you have children and other things become more important, or other things bear weight on your decision making, that balance is important. Now, I give you an example. In the UK, they have a program for trainees and they have a program for non-trainees. Okay. And I think it's the similar concept or similar thinking process back here in Malaysia too. If you follow the master's program, it's somebody's headache to get you through your training program. It's somebody's headache. Okay. You don't pass your master's, they will go and look for your supervisor and ask, what the hell are you doing? Why is this guy not passing? Okay. It's somebody else's headache. And it's the same in the UK. When you get into a training program, it's like going into a bus. Your bus will land at the FRCEM CCT destination in 6 years. It's a long journey, but you're already in the bus. Okay, it's the same with the master's training program. They put you through rotation, you do your exams and all of that. You pass your SN. If you fail your OSCEs or your last minute exam, you repeat, and then they come through some mitigation process. Somehow or other, your name will be on the specialist register. The parallel pathway is a bit different. It is your headache to become a specialist. So the burden is on you. It's the same with the UK. They have something called Article 14. And talking about this point, if any of you, once you all pass the exams, you have a lot of people who are headhunting, recruiters and all of that. They will offer you or training programs, SC2, SC3, equivalent SC4. The training program is only accessible when you go into the UK. Everything else is a non-training post. Okay. And people will talk to you about rotations, Caesar pathway, CESR, we can read that up. Yeah, Caesar pathway is something like the Malaysian alternative pathway. It's called Article 14, a Caesar pathway, where you go through the entire training program, and you work, you go through your rotations, you do this, you fill up your paperwork, and you tell the GMC, hey, whatever I've done is equivalent to a trainee who's followed the training pathway. Okay, this is my paperwork. Okay, but the funny part of it, or the problem of it, is when you finish your training, a structured training program, after 6 years, To sign you off as a specialist, the head of school needs to fill up a paperwork of 7 pages. That's it. Okay. To go through the CSER training pathway, you need to fill up a document 1,500 pages. Okay. And every attempt, you need to pay the GMC £1,500. £1,500 every attempt. Yeah. So that's the balance between structured and non-structured pathway. So what is the upside? The non-structured pathway is you can choose where you want to work. Okay. The training pathway, they will chuck you wherever they feel like they need the manpower. Okay. So if you really want to stay in a place, go through the entire training pathway, do some rotations, work in somewhere that you're familiar, then probably the alternative route or the CSER pathway in UK is more relevant for you. Anyone of you more than 40 years old? Then yeah, it is. I personally feel if you're less than 40, you should just go through the entire training pathway. If you come to a point where you finish MRCEM, you choose to move, and then you're being offered, jobs as a CSER pathway or any of that sort. Yeah.
Is there any difference in terms of working hours if you join structured and non-structured?
No, it's the same. Probably as a trainee, your working hours is more protected. If you say I've got a training day on Monday, they have to let you go. Yeah, they have to let you go. As long as you're not working on a night shift, they have to let you go. But it is a bit different if you're a non-trainee because you're mainly service provision. Okay. And when I took up my job in the UK, my first 2 years, the job was a non-training post. And it was very difficult. I had to beg to go see for my exams and all of that. So it's difficult you need to swap and all of that. So, but your contracted hours will be 40 hours a week, and that's it. You will not work more than that. If you are being forced to work more than that, there's one person called the EWTD Guardian. You can email them and say, I'm being forced to work more than 40 hours. The BMA will come after them. Yeah. So everything in that point of view is very, very protected. Timing is protected. The hours are protected. If you work extra, you might be called to work extra, but they will give back those days for you, or they will pay you as locum rates, whichever. But those stuff they're quite particular about. Anything else? Yeah. Now, I'm not sure who asked this question. I think it is it's a good question. It's a good question because I understand how things are in KKM right now with the contract situation and medical officers but at the end of the day, it depends on what your risk appetite is, how much risk you want to take. Once you quit KKM, there's no going back. And there's very little provisions for you to leave KKM and get cuti without a real reason. So if you say cuti melanjutkan pelajaran, you will get until I think up to 3 years. But if you just want to quit without any particular reason, then you're probably going to get into a bit of trouble. You probably can say you want to complete, once you finish your MRCEM, you want to go to the UK and complete your FRCEM, as in work there, take up a job, try before you buy. If you want to do that, you can say cuti melanjutkan pelajaran, go there. If you like it, you want to continue the training program, you can go ahead and do that. But the KKM will come after you. It's the same with a lot of my colleagues. That day after you finish your cuti melanjutkan pelajaran, they will send you an email asking, what are you going to come back? I want you to, and they won't say, can you report in 1 month? They say, can you report the next day? Yeah. So it's a bit of a difficult scenario. I think it is always the perception that the grass is greener. I worked in Malaysia, worked in the UK, I migrated to Australia. So there's always a perception that things are better, but there's always never a perfect place. There's certain things you'll be happy with, certain things you will not be happy with. It depends on what you want to live with and what you're willing to accept. So anyway, anything else on this particular question? It's okay. I mean, I think it's recorded, but if you want to ask me a little bit more private questions, you can ask me later. Yeah. Right. So the access block is a problem. It's a problem everywhere. It's a problem in Malaysia, I know for sure, because I remember doing my night shifts and patients all being stranded in the corridor, all waiting for medics to see and surgeons to see, waiting for a bed in the ward. And it's the same in the UK. It's the same in Australia. We have patients waiting for beds for 40 hours, still stuck in the ED. But the governance is a little bit different. I talked to you all about the 7 pillars of the NHS, and every hospital is ranked, or every hospital is, the performance is very strictly looked into based on the key performance index. And one of the main key performance index or emergency care standard is what we call by the 12-hour bed breach. Okay, if someone is waiting in the ED from the time where we decide to book the bed and they're waiting in the ED for more than 12 hours or nearing 12 hours, the execs and the people who manage the higher level management of the hospital will go crazy. Yeah, because the hospital will be fined heavily for that. And every 12-hour breach, the hospital will be fined. Yeah, so that's the same, the 4-hour rule. When you don't meet your criteria, the hospital will be fined, and then you don't get your yearly kind of like budget. So there's certain levels of kind of like admin for the hospital, and this is where the consultant role in the ED is very important, because as the consultant, there's very less. I mean, we do give advice clinically, we do the important procedures and all that, but our role comes with the risk management and management of the department. And especially in this case, in terms of access block, our role comes in terms of safety of the department. So that's where we actually speak to the management team, to say, you know what, my department is unsafe, you need to get people out, can we come up with a plan, whether you divert the hospital, whether you divert the ambulances and all of that. So this also comes to the question about FRCEM OSCE, because you'll be asked how you're going to manage department if there's an access block. You will be asked how you're going to manage the department if, let's say, you work in a hospital where there's 5 doctors and you've got 30 people incoming as a major incident. That is all part and parcel of the FRCEM OSCE. Because that's what you're, as a consultant in the UK, you're expected to do, how you're going to manage department in these kind of cases. Or you're going to be asked how you manage difficult trainee. One of my station was coming back to the FRCEM, because I just want to be focused on the FRCEM bit of the question here. So I'll give you an example. One of your trainees walked into a cubicle, and then the mom walked into a cubicle, a 14-year-old girl, and the mom came out screaming, saying that he exposed the breast without any chaperone. How are you going to manage the situation? So that's the FRCEM OSCE kind of question. Yeah. So, yeah, to answer question 8, it is the same everywhere. It's not going to be any different. Burnout is an issue. It is what we're facing everywhere. But I think in the NHS, you can turn around and say, look, this patient has been in the department 11 hours, 30 minutes. You're going to have a 12-hour breach. I want this patient out of the department right now. And they will have to make some sort of rules, because, like I said, the hospital gets fined very heavily if the patients stay in the department more than 12 hours. Yeah. Now, so all of you are sitting for the MRCEM, and it is the GMC approved pathway into getting registered in the UK. You have to complete all 3 parts of the exam. The important bit is within 2 years of passing your MRCEM, you must register with the GMC. Okay, or else then you will not be able to register with GMC after that. Okay, you don't need to secure a job in the UK to register with the GMC. Okay, it's different compared to other countries like Singapore or Australia. You must secure a job first because the hospital has to fill up their registration form. But in the UK, you don't need to do that. You can be registered, fully registered as a practitioner without a job offer. So my advice for you is, regardless whether you decide to stay or you don't decide to stay, just register with the GMC so that you're on the register once you pass your MRCEM. It's a laborious process. It takes about 2 to 3 months. It will cost you about £600, but at least there's one thing out of the way. Yeah, and you must present in person in the UK to kind of like do your final bit. They'll give you a decision in approval. Approval in principle, and you have to go in there to do your final face-to-face ID check. Okay, but there are other pathways. When I migrated, and then I got married. So my wife was working in civil, so she came over. So she was doing the PEDS paper, and we were having this discussion about, this is one thing I want to share with you, because sometimes it's about knowing the system, understanding what your risk is, and making a very calculated decision on what you want to do. And this comes to another thing that I want you to go and read up, because that is very useful. Now, when my wife, so she did the MRCPCH part 1, part 2, and the only thing outstanding was just the clinical exams. And if she does that, she passes that, she would get into the GMC specialist, the GMC register. And we were having this discussion. So the pass rate for the MRCPCH final paper was what, 20 to 30%. Okay. And for the MRCEM, the part C is about 30 to 40% for non-trainees or from non-UK origin. Okay, that's what you're looking at. And for the PLAB, the pass rate is about 70%. So my advice to my wife is just do the PLAB, which she did. She didn't have any trouble, and she got into the GMC register. And then she could start working in the UK, working in PEDS, and then she got enough of experience, and she passed the MRCPCH without any trouble. So there are pathways, and you just need to be aware of what the pass rates are. The college, so one thing good about in the UK is everything is transparent. There's no hiding. There's no hiding about whatever it is. And I give you an example. The pass rates for last year's are all published on the website. How many people passed, how many people sat the exam, how many are non-trainees, how many are trainees. And you'll be very interested to know that the trainees are almost 0% failure rate, especially for the FRCEM OSCE. Most of them sail through. This 90 to 100% pass rate for trainees. It's not because we get treated differently. It's not that they do something magical with us, but the entire process of this feedback, this workplace-based assessment, working in the UK, prepares you for the FRCEM. And this is the aim of the FRCEM exam, is just how would you function in a day-to-day work. That's in the UK, that's it. That's what it trains you or tests you for. The MRCP is also accepted. So those are the available pathways for you to get registered in the UK. Anyone has got any questions? No? All right. Shall we move on? Right. So I have been reading about a lot of issues with bullying, and I won't be ashamed to say that, you know, when I worked in Seberang Jaya, you know, as a house officer, you know, they did go through some amount of bullying, and the culture is there. And I know in the emergency department, we have, one thing I liked about emergency department, especially in Malaysia, was that there's no such thing as that bullying. There's a lot of very flat hierarchy going on, and compared to a lot of other ward-based specialties. And that's the thinking process, because even in the UK, even in in Australia, we're on first name basis with the consultants. I don't get people to call me Dr. Eugene or something. Just call me Eugene. It's the same, and we work together as a team. And bullying is heavily criticized, heavily criticized. And you can get someone deregistered by the GMC if, let's say, the person is confirmed for bullying. I know some of my colleagues who've just been under investigation for bullying who were put into admin leave. That means you cannot work clinically until the investigation is complete. So bullying is taken very, very seriously in UK and Australia, and there are very clear pathways to escalate, make complaints. The environment is supportive. I'm not painting a bed of roses for all of y'all. You will, as usual in emergency medicine, find a very annoying surgical registrar like, why do you need to admit the abdomen? Why can't you do a CT abdomen and send the patient home? You will have that, but people are generally nice. People don't abuse you. People talk to you nicely, and if people do otherwise, there are very clear ways to escalate and get them into trouble. Yeah. Any questions? And the BMA is actually very useful. You pay them a lot of money, but they actually do work. The GMC, you pay them a lot of money, they don't do work. Yeah. And what I mean by that is, let's say if you have any problem with your pay, or you think you're being bullied for your pay, you can contact the BMA. They will look through your contract. They have a contract checking service. If you're not getting your leaves and you're supposed to get your leaves, you can contact the BMA. If you're not getting your maternity leave, you contact the BMA. And they're very useful. They're very, very useful. One more thing that you need and must get in the UK is medical indemnity insurance. Yeah. So those are the stuff. I think I'm slightly early. Any other questions which I have not answered? Any burning questions? Anything you want to ask? Oh, okay. I thought there was 10 questions, but
Yeah, there is an 11 one.
Oh, sorry. Tell me what.
It was late. It was late. I think it goes by. Is it possible to get the OSCE practical run through like a practical session? I mean, like, because everything is kind of new.
Yeah.
Over here, like, whether we can we can collaborate with certain individuals that we can actually run a mock exam, like a MCAM exam. Is that possible in the future?
I think that is doable. A lot of us who pass the exams, like the first few ones to pass the exams, me, Nicholas Chua, and all of that, we're all based overseas already right now. And we do run quite busy portfolios as consultants. But what I found useful was this website. Everybody has Facebook nowadays, right? Yeah. So it's a group called FRCEM Malaysia Candidates, something like that. The best thing to do is come up with your own group, okay, and practice. And it is not as difficult as you think it is, because if you have the book and you have the mark sheet, you're expected to just mark. That's all. There can be some sort of a study group and all that, but it's very difficult for, I think, a lot of people. Probably you've got some people who pass the MRCEM still around, you probably can arrange that. But it's very difficult for anyone to actually commit and say, look, we can do this. And even if it does, it's going to be online, which is not really going to be really useful for preparing for the exam. You need to be someone who actually sits and, helps you. I'm looking at y'all, like, how many of y'all here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 of y'all right now. And I'm sure y'all can actually come up with a good number of groups and to practice for the exam. When I sat for the MRCEM, it's just me, finish. End of story. Who do I practice with? No, I have no idea. But I was helped a lot by Dr. Adi, Dr. Kursi, because every session that you do helps you, like the ATLS Molage, you're definitely going to get an ATLS or an APLS or an ALS station in MRCEM OSCE. That's a given. And the whole idea is not about you going there to clear the tick box. The whole idea is how do you perform when someone sees you in the exam, because that's what really matters. And that's what we call by playing the OSCE game. And this is, I think you all should take the time to read my paper. Actually, I'm not kind of like promoting it purely because of no reason. I think it's a lot of information that you can learn then. So this is what I mean by playing the OSCE game. When you are driving the car, you want to look to the left, you must show your examiner or someone who's in the car with you that you're actually looking left and looking in the mirror. And that's what the exam is all about. If you're doing an examination, physical examination, you walk into the cubicle. If you're looking for scars in the chest, you must really look for the scars in the chest. Okay, if your patient is like this, and you say you look for scars in the chest, you don't get a point. Because how are you going to look at the scars for bats and all of that in the armpit? So you don't get that point there. So the whole idea is, this is the best example. You walk in the cubicle, respiratory, chest examination, cardio examination, you walk into the cubicle, you have to lift the arm, ask them to lift up the arm to look for the scars. And then you actually show them that you're actually looking at it. And that's where you get the point for it. Those are the easy marks. So this is the one important point I want to mention when it comes to exams, OSCE and all that. Don't miss out on the easy points. Because, it's really sad if you do that. You walk into the cubicle, what are the easy points? Can anyone tell me? Has anyone started preparing for your OSCE? What are the easy points? Introduction. Yeah. Yeah. So what is the more important than introduction? Wash your hand. You get a point for washing your hand. Yeah. You get a point for washing your hand. You introduce yourself. You check for the patient's name. You confirm the patient's identity. All of these are easy points. Easy points. Okay. And then for a simple explaining, you might get a very simple session. Explain to this patient how to use inhaler, salbutamol inhaler. Simple. Follow your format. Go into the cubicle, wash your hands, introduce yourself, ask your patient if they're in any pain, confirm the identity, explore the indications, okay? And then explain to them, talk to them about the salbutamol inhaler, what is for, what are the indications, when you actually seek for help, signposting, checking for understanding, and then providing them with leaflet or written advice and all that. And then at the end, ask for questions. All of these are points, and that's it. That's your template, that's it. And the other important thing about practicing is you need to be able to practice under time. You must be able to orientate yourself to understand what is 7 minutes to 6 minutes is roughly in your head. Because some people, they go in, they rush. Some people, they take too long. And both will cause you trouble. The last point is easier said than done. I've said for a number of OSCEs in my life. Once you're done with the cubicle, or once you're done with the station, forget it. Move on to the next one. Doesn't matter whether you did well or didn't do well or whatever it is. Oh, I could have said this, I could have said that. Doesn't matter. Done and dusted, move on to the next one. Yeah. Because you never know, you could have done more really well with a particular station. We are probably the worst judge of our own kind of competence and also performance. So that's pretty much it. I think I've answered most of your questions. Anyone else has got any particular questions, especially those attending in Zoom? I got 16 participants on Zoom. Wow. You can put on the chat box. And my slides is with Nuriman. So
Hi, giving my MO's announcement. Can you hear me?
yes, hi.
Thank you for giving us such a good talk. I'd like to ask you, do you recommend or advise our Malaysian students to stay back at UK to work a few years, or do you think they should come back to us? You think there'll be a brain drain with this FRCEM exam?
Okay. I think that is a very good question. Now it depends on what you want out of life at the end of the day. I think this comes back to my statement that there is no perfect place. I still miss Malaysia very badly. But I have particular reasons why I decide to move to Australia and stay there. Brain drain may or may not be there, but how you function and how you're treated as a consultant in the UK is a bit different to how you'll be treated and how things are here in Malaysia. When I mean when you mean say go and stay back in the UK and then come back, I think there's a lot of positive thing towards from that aspect. Especially you go there, you see new practice, and then you are exposed to a new kind of thinking process, and you bring that entire thinking ideas, the knowledge and the kind of views back to Malaysia, and you just widen that knowledge base and that pool. So I think there's a lot of positive thing about it, or else, you know, those who work around that specific area just have that same kind of thought process. And I think in terms of where emergency medicine wise is concerned, is not really good. And this is why in Australia, they encourage a lot of people to come from, you know, Netherlands, from the US and all that. They take people from a lot of papers so they can consolidate the knowledge and they can improve the practice. So yeah.
What about the prospect of doing subspecialty training in the overseas? Is it a bribe? Do you have to pay for it and all that?
So you don't need to pay for any training in the UK. Actually, this is a very good question, Chan, because now I was talking about a non-training job as a registrar in the UK. When you take up a training post, your pay drops. Okay, tremendously, because you're in a training post. They have particular pay for that, but you don't need to pay extra for it. The subspecialty training in the UK for emergency, where emergency medicine is concerned, is very, very limited. Okay, there's only a few. There's pre-hospital emergency medicine, there's peds emergency medicine, and you can do dual specialization with intensive care medicine. And that's as much as it goes. Yeah.
I think that's a very important factor to consider for our MOs who plan to stay on. Because in Malaysia at the moment, the subspecialty opportunity is actually quite high. So if you apply for it, definitely you will get it. But it's just that there will be a bond of 600,000. So you probably have to stay on if you want to do subspecialty training here.
I can tell you, for someone who's worked in Malaysia, UK, Australia, the subspecialty training here is very advanced. You probably don't get a lot of subspecialty that you get here compared to Australia or in the UK. You know, in Australia, you probably can do toxicology extra, some other subspecialties like GP and stuff like that. But I think Malaysia is pretty advanced in terms of subspecialty. So that's something you need to consider. And like I said, in the wider aspect, it's about what you really feel is important for you. Not everything is about money. It's a lot about job satisfaction. There's a Japanese term called ikigai. There's no English translation for it, but you can Google it up. It's about what is important for you and what makes you satisfied in a job. So yeah.
Yeah, hopefully you are so satisfied. I'm very satisfied with my place here. Thank you again for coming.
Thank you, Jan.
Leave you all. Thank you.
All right, so if there's no further questions, thank you everyone for attending. My slides are available. Like I said, Right, great. All the best. I will end the recording. Yeah.